It's my pleasure to introduce Dr. Zuckerman. He is the head of infectious disease for the Hackensack Meridian Network and a board-certified infectious diseases physician who specializes in hospital epidemiology, infection prevention, and patient safety. Unfortunately, Dr. Bader could not be with us tonight. He is the Chief Clinical Officer of Hackensack Meridian Health and a board-certified OBGYN. Dr. Bader has been with us for the past 6 months, and we appreciate both his and Dr. Zuckerman's guidance. So I will turn it over to Dr. Zuckerman for a brief presentation, and then we'll open it up for a discussion.
We'll briefly go over some stuff, really kind of just re-emphasize where we are in the pandemic, and talk a little bit again about vaccinations. Clearly there is exciting news since the last time we talked in terms of approval of COVID vaccine for children less than 5 years of age. And so we'll go into a little bit about that as well. So, you know, I always start this off with what's our present state, and this is what's occurring in New Jersey. The upper left here is the number of new cases per day. And you can see that we peaked probably a couple weeks ago in terms of the number of new cases. Did not approach the levels that we saw in the Omicron surge in December and January. Hopeful that this trend will continue. But as we know, with these variants and subvariants, it can always throw us a curveball, and we can have you know, a new surge or a mini surge. Unlike the previous surges, while there was a lot of disease in the community, there was less so in the hospitals. So we saw a slight increase in hospitalization and really no increase in the number of patients who are in our intensive care units. And similarly, we did not see a spike in deaths during this time frame. And I think, you know, this is attributable to the fact that many of us have some immunity to COVID-19 at this point in time. Either we've been vaccinated and hopefully vaccinated multiple times, or we've had natural infection in the past. And while these measures may not prevent us totally from getting infected again, or getting infected in the first time, it does seem to ameliorate the severity of the disease so that we're not seeing the rates of hospitalization and deaths that we saw previously. This is just looking at community transmission, and I put this up here just to remind myself that there still is a lot of disease in the community. And I'm sure your experiences are like mine. I feel like many people have moved on from COVID-19, but there is still a risk out there, and depending upon your individual circumstances, this may guide you in terms of what measures, protective measures you may still want to do. So we are still at a high level. Hopefully this will start decreasing in a couple of weeks. Again, this may be underrepresentation due to the home testing that's available, and not all people who get home tests get captured or reported to the health department, so we may not capture those cases to begin with. So I just put this up here to remind me of why this has been going on for so long, and this is about the virus mutates as it reproduces over time, and each time it mutates, it gives itself a selective advantage, either by being more easily transmissible between individuals or evading our immune system responses. And this is just, again, a schematic of Omicron, the spike protein, and all the yellow brownish areas are where the virus has changed from previous versions. And that's why it was so radically different. That's why we saw such a surge back in January. So what does that mean? This is looking, and I've shown this slide before, about variants and subvariants over time. You can see that there are different colors here. This is, you actually don't see it anymore, but this light, I guess, purple represented the original Omicron variant. And then these are all the subvariants that have arisen. And you can see that over time, when a new subvariant emerges, it has a selective advantage over the preceding viral strain that's circulating, and then kind of crowds it out. And then that subvariant becomes the predominant player causing infections. So we've been experiencing this, it's called BA.2.121. And the new subvariants that are beginning to increase are called BA.4 and BA.5. And these were caused surges mainly in South Africa. But you can see over the last 4 weeks that the percent of new infections caused by these subvariants, new subvariants, is increasing. And I fully expect that in the next 3-4 weeks, maybe we'll have BA.5 and BA.4 as the predominant circulating strains. Whether that means we'll have another surge is not clear. Hopefully, again, that there's enough, hopefully there's enough similarity with the subvariants that, if you had the vaccine, if you had the infection, you have some protection against this subvariant. And also with people getting a second booster now, that may also provide additional protection, or will provide additional protection. So those two factors may mitigate the fact whether we see this increase in infections due to these two subvariants. But it's reasons like this that I remain concerned about COVID-19, because it's okay if it changes a little bit, but if we have another radical change like we did when Omicron came, then potentially we may see a resurgence of severe disease. So really a lot of unknowns, but I think there's a lot of hope that this virus has mutated as much as it can, because at some point, if it mutates too much, it can't survive anymore. So hopefully we're near the end of that. And, I think what's really important and what we're seeing is that vaccines may not prevent you from getting infected, but it does prevent you from having serious complications, hospitalizations, or even dying from the infection. And that has really stood up throughout the past year and a half since vaccines have been introduced. So if there's any reason to get the vaccine, it's really to enhance your immune response so that you don't get a severe disease and that you can quickly recover from the infection. So this is individuals who are unvaccinated versus individuals who have been vaccinated in terms of hospitalizations. This is looking at, so this light purple here is now people who've gotten the primary series plus 2 booster doses. So up until now, we primarily showed the primary series plus 1 booster dose, which I think is one of these lines here. But what you see is that, again, the booster doses, there's not much difference in these graphs. So people still can get infected even with 2 booster doses. But you do see a further splaying out of people dying from the infection, and that even getting a second booster provides additional protection against severe infection and death compared to individuals who only had 1 booster. So again, re-emphasizing that maintaining our immune responses is a very important mechanism to keep us as not to prevent us from getting seriously ill. I've shown this before. This is just the vaccine series. I think I'll just briefly go through that and get to the vaccine update. So there is a new vaccine that was approved by the Advisory Council. It's called Novavax. It's a different mechanism than the other vaccines that we have available. And it's a 2-dose vaccine. So it was approved by the Advisory Council, but it has not yet been approved for emergency use authorization by the FDA because they're still reviewing the manufacturing process. So that has to be certified first before the FDA would move on to a formal approval. This was a study that just came out, and many people ask, well, I had COVID, why do I need the vaccine? Or should I get vaccinated? And I think this study really showed some of the benefits from getting additional doses of vaccine, even if you've been infected. So this is looking about protection against the Omicron subvariants. If you had a previous infection, then you are protected up to 50% against symptomatic disease. If you only had 2 doses of vaccine alone in the past, you really at this point have no protection. So it's the primary series in and of itself is not going to provide the protection against infection that you would see with these other type of variation arrangements that are listed here. For individuals who had 2 doses of the vaccine in a previous infection, slight increase to 55%. If you have 3 doses of vaccine alone, your protection is up to 60%. And then 3 doses of vaccine and previous infection, your protection is up to 76%. So there is some, they do build on each other. And, I think this really helps emphasize that there is additional benefit to getting vaccine, even if you've had a previous infection. And so these are against symptomatic infections. All these scenarios were protective against severe or critical infections. So again, having partial immunity does have its benefits. And then the big news this past week was the FDA approved vaccination for 6 months to 5 years of age. This is looking at, since the pandemic began, the number of children who have contracted COVID. And you can see that they are in the millions, not as much as adults, but a significant number of our pediatric and children and adolescents have been infected with COVID-19. And you can see that the amount of disease correlates with the type of strains that are circulating. Even though disease is milder in children, it still can cause severe illnesses and death. And I believe that in kids less than 5 years of age, there have been upwards of 200 to 300 deaths that have been reported. Clearly a much smaller number than the million of adult deaths that we've seen. But it's not insignificant. And for children between the ages of 0 and 19, this is the leading cause of death for infectious disease. And then for people between the ages of 1 and 4 years of age, it's the 5th most common cause of death in that age group. So, it's not insignificant. And, you have to weigh these risks, and even though they're small, but they exist, versus the risk of the vaccine. And knowing that we've given hundreds of millions of doses of vaccine without any significant issues, certainly that to me favors vaccinating over taking these small but very real risk. And this just looks at hospitalization since December. So this would be with the Omicron period. And you can see that children who test positive and with COVID, that nearly a quarter of them end up in the intensive care unit. They require high flow oxygen. Some of them require a machine for breathing. Death is very unlikely and very rare in children. But, you know, these are traumatic events for a child, right? And so even though the numbers are small, if it's your child, it can have significant impact on that child. So what was approved? There are the two vaccines, or the messenger RNA vaccines, the Pfizer and the Moderna. And there are differences between the two, which I kind of highlighted here. So the Pfizer vaccine is a smaller dose. It's only 3 micrograms of the product that's injected. That's about 1/10 the amount that's given to adults. And it requires 3 doses to get to a level of antibodies that are deemed to be protective. They originally started this study looking at 2 doses, but really we're not having a high enough response. But when they added the 3rd dose 2 months afterwards, they did see a further boost in our antibody levels and presumed protection. The efficacy, you know, this 80%, I think is, you know, it's hard to, the FDA right now is not even assigning an efficacy because there were only 10 infections in the study. And they need to continue to follow this for a longer period of time to see how many infections will occur in the vaccine group versus the control group. The Moderna vaccine is different. It has a higher dose. So it's 25 micrograms of the messenger RNA. That's a quarter, 25% of what's given to an adult. And this is a 2-dose series. So 3 doses versus 2 doses, a low dose versus a high dose. This was a much larger study, and it did show benefit against symptomatic disease. You know, not as robust when vaccines first came out, but upwards of 50% in very young children. Again, very effective in preventing any type of complications. And the side effects were slightly higher in terms of fever with the Moderna vaccine than the Pfizer vaccine, presumably because it's a higher dose and probably more of an immune response to the vaccine administration. So what's recommended now is for children 6 months to 4 years of age, you can give Pfizer, and it's a 3-dose series. The first 2 doses are 3 to 8 weeks apart, and then 8 weeks later is your 3rd dose. And so it's completion of the 3 doses that is considered the primary series versus Moderna, which is only a 2-dose series. And I will say that for the pediatric population, because the doses are so different, you can't mix and match these 2 vaccines. So if you start with the Pfizer vaccine, the child should complete that course with a vaccination with a Pfizer vaccine. Similarly, if they start with a Moderna vaccine, they should complete the course with the Moderna vaccine. I would not switch unless there was absolutely no way to get the other vaccine that they started with. For moderately or severe immunocompromised, they're both recommended to be a 3-dose series to be considered and to have the primary vaccination. You'll notice there's no recommendation for boosters yet in children. That's something that the studies really haven't been done. They have not been done. And I think that's evidence that'll come out over time is whether children will require a booster dose just like us adults need booster doses to kind of maintain our immunity against infection and severe disease. And then this is, I think, my final slide. This is just a reiteration. It's very busy now that I'm looking at it. And just that the number of doses that you're eligible for, it depends on your age and on whether you're immunocompromised. Just a reminder that a second booster is now recommended by the CDC for anyone over the age of 50 and anyone who is severely immunocompromised or moderately immunocompromised. And those are candidates for the second booster. If you're a healthy individual and you're less than 50 years of age, currently you're not qualified or as a candidate for the second booster dose. And I think that was it. So actually, I'm going to have to try to change this slide now to primary series and at least 2 boosters to stay current as much as possible.
Thanks, Dr. Zuckerman.
Yes.
Okay, does anybody have any questions for Dr. Zuckerman about the presentation or questions that you brought with you?
No, Sandra did.
Yes, I'm sorry.
Yeah.
Yes, I do have a question. I just was reading an article on the Paxlovid. I'm not sure if I'm pronouncing it correctly.
Paxlovid, yes.
Yeah, and I'm not sure if I read it properly, but they were saying that the group that received the medication compared to the placebo group, that there was no difference in the recovery rate.
Right.
I think I saw that in Newsweek, but I'm not 100%.
So yeah, you are correct, but we have to put it in the proper context here. So Paxlovid is a antiviral that someone can take if they have mild disease and they're at risk for progression to more severe disease. For the group that is that's at for going on to severe disease, so that would be older individuals who are immunocompromised. Paxlovid is beneficial in that group in preventing progression of the infection. The study that you're referring to and that just came out is looking at giving Paxlovid to individuals who are not old and do not have other medical conditions that put them at risk for progression. And in that group, there really was no difference in outcome between individuals who got Paxlovid and versus placebo. So if you're 40 years old and healthy and get COVID, there doesn't seem to be any additional benefit by taking Paxlovid versus just taking your Tylenol, Motrin, and whatever else you need to symptomatically improve. If you are 75 and you get COVID, then Paxlovid will be beneficial for you in lowering the risk for developing severe disease.
Okay, thank you so much for clarifying. And may I ask you one more question?
Of course.
How do you explain when one person in the household who you live with and are intimate with gets COVID and then the other person doesn't? I mean, that baffles me.
Oh, it baffles a lot of people. It's one of the mysteries.
Okay.
I think, really, we're all, we all have our individual immune responses. So we know that transmission in a household is more likely to occur to other members in the household if they're unvaccinated versus transmission to members of the household who are vaccinated. So vaccine status plays a role in this. Similarly, the vaccine status of the person who is sick. So if I never had COVID before, never had the vaccine, I'm more likely to have more virus that I can spread in the environment than if I've been vaccinated several times. The viral load, we call it the viral load, is lower and therefore less likely to transmit to other individuals. But it's known, whenever you have an infectious disease and in a closed space, not everyone is going to get it. And so it's a percent of the individuals. And with Omicron, in an unvaccinated household, it approached 40 to 50%. So there are, different nuances as to why people don't get infected. And if I certainly, every time if I'm near someone who had COVID and I don't get infected, I knock on wood and thank the vaccine.
Okay, thank you so much.
You're welcome.
Thank you.
Anybody else have any questions? Feel free to use the chat too, if you're unable to unmute yourself. I do have a question about the vaccine for children under 5. Parents, just as they were with the vaccine for older children, seem worried about the side effects that their children might experience. Are there the same concerns there? Are the side effects heightened in the younger children in any way?
Yeah, thanks for that. No, there's no increase in side effects. In fact, in the young adults and adolescents, older adolescents, one of the concerns was a very small rate of myocarditis that can occur with the vaccine. It occurs less frequently than if you got the COVID infection. You're more likely to get myocarditis. But in the studies in this younger age group, there were no cases of myocarditis, inflammation of the heart valve. They have the same reactions that we have, right? They have a fever. They may express it differently. So a 6-month-old is not going to complain their arm hurts. They're going to be irritable and grouchy. And so, but the side effects are very similar, and all of them are self-limited in nature. So really no concern that there's anything that should emerge in this population. And again, given the hundreds of millions of doses we've administered throughout the US and the world, the safety of this vaccine has really proven itself over time.
Okay, anybody have a question they would like to ask? This is our last opportunity to ask our questions to Dr. Zuckerman. And I said this in the last presentation, at this level of expertise, so please take advantage of this. Ask your questions, get the information, bring it back to your families. This is all so helpful. So for parents who are vaccinating their children and they're watching for side effects, if their child gets a fever or starts to have these side effects, is it best to give them Tylenol or to let them just their bodies work it through?
No, I absolutely. If they have fever or they're irritable, you can treat them symptomatic with Tylenol, and same for adults. So there's no additional benefit to trying to work through the fever. Your immune system is going to respond either way. So Tylenol is not going to suppress your immune response. There's two more comments about the new pediatric vaccines. So I show the difference between the 3-dose series and the 2-dose series. So if someone wants to get their child vaccinated and protected quickly, then that would favor using the Moderna vaccine, the 2-dose series, because that's going to be done within 4 to 8 weeks, as opposed to I guess it's 16 weeks for the Pfizer vaccine. And it also means, you have one extra visit with the Pfizer vaccine to get to have the child fully vaccinated. It's not clear to me, and I don't think, and we're not going to be doing this at Hackensack. We're not going to be offering both vaccines for pediatrics at our sites, right? So some sites will have the Moderna, some sites will have the Pfizer, just because of the differences in the schedules and the differences in dosing, the difference in the time intervals between doses. It became a bit messy trying to manage all that. So the pediatricians, if a pediatric office is probably more tuned and better able, and so they may get both doses available. But when we're dealing with our vaccination clinics that don't normally vaccinate young infants like this, we want to make sure we do it safely. And the safe way seems to be to administer, to just choose one for that site, so they're most familiar with it. So if you do have a preference for one over the other, and it may make sense to touch base wherever you're going to get the vaccine to see what products they're offering. Maybe they offer both, or maybe just one.
Okay. Stephanie asks, has there been more research about long COVID and who is more likely to get it?
Yeah, so long COVID is really an unknown in terms of what exactly is causing long COVID, and what is the prognosis of people who get long COVID, and what's the treatment. So there is a lot of research going on. It's a hard thing to really measure because we don't have one single definition for long COVID, right? So we have one definition for COVID infection, right? You get a new virus, you get positive test, you have COVID. But what is long COVID? That varies. A lot of variance in the definitions, and they have not really found markers yet that are indicative of either you having long COVID or maybe susceptible to getting long COVID. So meaning that there's not an inflammatory marker or some specific thing that we can measure in the blood that says you have long COVID. So it's a bit problematic from that standpoint. It seems to be slightly more common in women than men. There's some recent stuff that came out that suggests that long COVID is less likely to occur with the Omicron variants than it did previously. And also some evidence that vaccine may lower the risk of developing long COVID. Of course, with every several studies that show one thing, there's probably another one that shows something totally different. That's how much is going on out there. So that's where it's at right now. There are centers that specialize in long COVID, and if someone is still symptomatic 2 months after their infection, it would probably be best to go to one of those specialty centers so that they can get the latest management recommendations from people who are seeing it as opposed to a general practitioner.
Are children getting, oh, sorry.
So go ahead.
Are children getting long COVID?
Yeah, it's they can, but it doesn't seem to be as frequent.
Okay.
So yeah, it's not zero, but as with other things that we saw with COVID, the severity, the long COVID occurs much less frequently in in our younger population than in older population.
If they were to get it, could it affect their development?
So it could, yes. There are a lot of things that could affect the development. This whole pandemic has been, a disaster for development in our young children. So yes, you can have delayed development, if you get COVID infection. But we've also seen, delayed development because of shutting down schools and doing home learning. So there's a lot of factors going on, but overall, it has not been good for the well-being for our younger population, certainly their education. There's a question about distribution of the vaccine for children. Will it be available at pediatric offices? That will depend on the pediatrician. So they should have the ability to order it from the state so that the state will dispense it. I don't know if you saw the news, I think it was last week, that Florida Governor DeSantis was not going to order vaccine from a state level, but subsequently it's being allowed that the pediatricians' offices will be able to order the vaccine directly. And not through necessarily the state if they're not ordering it. So I would contact the pediatrician and perhaps if they're not giving it, they will know who is giving it. And I'm not sure about the retail pharmacies, whether the CVSs and the Rite Aids will be administering that. I'm just not familiar with whether they'll be distributing that vaccine or not.
Okay, Lisa asks, can you speak to the similarity of long COVID to fibromyalgia and chronic fatigue syndrome?
Yeah, so that's an interesting question. And I think, it's on one hand, there are similarities. There are, in fibromyalgia and chronic fatigue, and COVID, there can be a lot of subjective complaints and issues with the general health, with a paucity of objective findings. So, meaning that if I'm complaining of joint pain, I may not have objective finding of fluid in my joints. So there is similarity there. Similarly, with fibromyalgia and chronic fatigue, no real good biomarkers to identify those infections, those syndromes. So that is similar as well. But we do know, and the etiology of some of this is fibromyalgia and chronic fatigue is not entirely clear. Long COVID clearly happens after a COVID infection, but maybe it's whatever the mechanism for developing long COVID. Maybe if they find that mechanism, maybe a mechanism that can explain some of these other syndromes. So I haven't seen any studies yet right now that is comparing the two or looking at the two, but I am sure that's going to be something that we'll kind of mix into the pot and see what differences, if any, and what similarities there are between those different syndromes.
How do we gauge, this is my question, how do we gauge COVID risk levels these days? I remember at the very beginning, they had all these different calculators. You could go on and look at your region. Am I frozen?
Yeah, no, you're fine.
Okay.
Okay. Hopefully.
But
so you're talking about getting the risk of getting COVID in the community?
Yeah.
So I use, what I showed earlier, the state that's red, that's reflective of community transmission. And as that goes down to orange and yellow, that would suggest there is much less burden of disease out in the community. So when it's red, I'm still careful. No, when it goes to yellow, I'll probably be more, adventuresome out in the real world, if I remember how to interact with the real world. But so I use that as a marker. And parenthetically, when several weeks ago, when we were really seeing an increase in community COVID, and I was seeing a lot of people who were getting infected even though they had a booster already. That really was the trigger for me to get my second booster. So whether I remain COVID free or not, and maybe luck, maybe it's due to the two boosters. I like to think that it is, but those are some of the things that you have to assess, and it depends on your individual risk factors. If I'm 80, I'm still going to be very cautious out there because it could be quite severe, as opposed to our young adults who've long left COVID behind and have moved on with a lot of parts of their lives.
Okay. We had a staff member who had a question, and you touched on this in your presentation, but I'm going to ask anyway. What is your response to those who claim that they don't need to be vaccinated because they have recovered from the COVID infection and are therefore immune?
Yeah, so you're right. I did touch upon that, and that recent study really does demonstrate that vaccine on top of a previous infection does kind of rev up the immune system even better than just infection alone. We know, immunity wanes, whether you had an infection or whether you got vaccinated. Over time, it becomes slightly less protective. And as the virus keeps changing, it also becomes less protective. So having previous infection does not equate to immunity from getting infected again. And so I would not, if I want to minimize my chances and my risk of either getting infected or getting any complication, I would take a vaccine on top of the infection that I may have had in the past. If you were infected with, the previous strains, Delta, Alpha, I don't remember if there was a beta, but there probably was. If you were infected with those strains at this point in time, you have you're not immune at all, right? You're just as susceptible as what I showed. Individuals who had two vaccines have no protection at this point in time. And that's because the virus has changed its shape so much that it escapes whatever immunity that we did have back against those other variant strains.
Is that the normal course of things to have so many variants?
No. I'm not a virologist, so whether it's normal or not, I don't think coronavirus was felt that it would mutate as frequently as it did. Certainly, we have strains of coronavirus that cause the common cold, and that doesn't change. Influenza, we know it changes slightly each year. But not to the extent that we're seeing every 2 or 3 months, maybe we're seeing, changes in the virus so that it's now taking over and crowding out the other strains. So that type of frequency and is nothing that I've experienced and we've experienced in an outbreak before. But again, the virus can only mutate so much, I believe. It can only mutate so much before it can no longer survive, right? Mm-hmm. And so maybe that's that's one hope, is that that's when it becomes more like the endemic into the community, be more stable over time, and not go through all these changes that we see every couple of months.
Mm. If it does reach the end of that or starts approaching the end, will the variants slow down? Will the changes
Yeah.
slow down? It'll slow down.
That's the hope. Yes.
Okay.
Um,
Okay. Okay. And then one question about pregnancy. Are there any situations in which a pregnant woman or woman who is trying to become pregnant should not get the vaccine?
There's none that I can think of. There's dozens of reasons that I can think that they should get the vaccine. It clearly is protective for the mom, prevents complications, COVID complications during pregnancy, and provides some protection to the child, to the newborn as well, because those antibodies will cross the placenta and provide some protection for the newborn infant for several months after birth. There's no effect on fertility. That was kind of the concerns that when the vaccine first came out. Again, with hundreds of millions of doses, things would have emerged at this point in time if there was any untoward effect on pregnancy or on fertility. And clearly, what's emerged is the benefits to the individual, and not these risk events that people are concerned about.
Okay. If nobody has any more questions, we'll wrap up. Dr. Zuckerman, I wanted to thank you so much, and Dr. Bader, for being with us for these past 6 months and hopping on and keeping us updated. All of this information has been so helpful for us to take back to our families and help them navigate all of the constant changes that are happening. So we're so grateful for having you on with us. Thank you so much.
Thank you for having me. It's been a pleasure, and anything that I can do to help inform individuals, is a good thing. And we mean Dr. Bader and myself, greatly appreciate the opportunity to talk with you and your organization and to help out in a very small way where we could.
A big way. It was a big way. Thank you so much. Okay, everybody, thanks for joining us. Have a good night.
Stay safe.
Thank
everyone.
you. Stay safe.